endocrinology, and we are going to talk about some of the new technologies that we use mostly in the management of patients with juvenile or type 1 diabetes, but a lot of these technologies are also approved by FDA and are being used for management of type 2. So it applies to all the patients. So as you have all heard about diabetes whole day, all the diabetes talks start with the reference to the big trial that was done in 80s and early 90s, DCCT trial, Diabetes Control and Complications trial, which confirmed that why do we care? Why do we want to have good glycemic control? Because it pays back, and you can affect the outcome by having good control. And our best indicator, one of the best indicators of a good glycemic control, is hemoglobin A1C. So the studies have shown that 1% reduction in our A1C can reduce the long-term complications of diabetes by 50%. And especially when we are talking about type 1 diabetes, we are talking about decades of body's exposure to high glucose levels. And of course, the main concern is how to prevent those complications. So these are the guidelines from ADA. Based on the age of the patient, we have different cutoffs for our target A1C. Everybody knows, of course, hemoglobin A1C, what it is, so we're going to skip that. But actually what it does, hemoglobin A1C is a reflection of the serum glucose in the past 3 months. And as you see here in the table, if we have a hemoglobin A1C of around 7, our average glucose in the past 3 months have been around 150. Now this is average glucose. The target of A1C, of course, for adults and our older adolescents is as close to 7 as possible. Some of the adult endocrine associations like ACE, American Association of Clinical Endocrinologists, they even recommend targeting for A1C as low as 6.5. In our youngsters, in our toddlers and preschoolers, we usually aim for A1C of close to 8 or below 8, around 8, not really trying to bring it too low because of the effects of low blood glucose in the nervous system and on the brain development. So to achieve a good hemoglobin A1C, of course, we have different types of treatment with insulin. We have the conventional way that has been around for many, many years. It traditionally has been the use of insulin injections twice daily, NPH, with a combination of either regular insulin or rapid-acting insulin analogs. More recently, we have come up with the basal bolus insulin injection. That is actually multiple daily injections. It's more physiologic and can help the patient and the families to be able to manage the diabetes in a more physiologic way. And then we have the continuous subcutaneous insulin infusion, or our pumps, which is basically the gold standard for treatment of type 1 diabetes. Why do we think that pump is the best to date? Because of many reasons. One being the day-to-day variability in the absorption of insulin. So studies have shown that the long-acting insulins have up to 30% day-to-day variability in the amount that gets absorbed in the body. But the rapid-acting insulins have only about 3% variability. So of course it's a lot more reliable to have the rapid-acting forms. Now, as we all know, the type of insulin that goes into an insulin pump is only the rapid-acting insulin. Pumps have generally one reservoir, so we can't use combination of insulin. So we only use the rapid-acting insulins. So again, in one study that was published in 2004, achieving the target A1C in patients that were on an insulin pump, 50% of patients. On those who use the multiple daily injections, only 12%. So basically, this is some other reasons. With the use of insulin pump, we can go to decimals of 1 unit. With insulin injections, either we use the pen or the insulin syringes, our increments are as low as half a unit. But thanks to the industry, today the insulin pumps can deliver up to 3 decimals of a unit, 0.005, which is a very small amount of insulin, almost in micro drops. And of course, especially we think about our younger patients, our toddlers or preschoolers, that's what really makes a huge difference. Besides, we are going to get back to the more details of insulin pumps. There are other, technologies that we use in the insulin pump that also helps with the management of diabetes in a much more accurate way. Traditionally, with the conventional twice daily insulin injections, patients have to follow a meal plan, have to eat 3 meals and 2 or 3 snacks a day. They cannot skip a meal or have extra amounts of carbohydrates. It's not recommended. With use of the pumps, you can have more flexibility, and it's again more physiologic. So there are 3 different insulin pumps on the market in US at this time. They all almost have the same features. The way that the pumps work is, again, they have one insulin reservoir, which, how many people here are familiar with insulin pumps? How many would like to know more about insulin pumps? Okay, so let's go into the details. So insulin pumps are generally this is the size, as big as our beepers, pagers, and have one reservoir for insulin that they fill it with the rapid-acting insulin. So 3 types of rapid-acting insulin can be used, either Humalog, Novolog, or Epidra. And there are different settings for the pump. So for the base, because any patient who has type 1 diabetes and many patients with type 2 need a basal amount of insulin throughout the day. And that can be delivered as a basal rate, as again, in very small increments. Now, one very helpful feature that the insulin pumps have is what we call it a temporary basal rate, meaning that not only during different times of the day you can have different basal rates, you can lower your basal rate at night, you can have higher basal rates in the early morning hours that we have that dawn phenomenon. But also patients who have the pump have this flexibility to self-adjust their basal rate based on their activity level. If they're participating in sports, they can lower their basal rate. If it's a time that for any reason, emotional, or maybe they have had a sickness, their blood sugar has been running high, they can increase their basal rate, and that can be for a period of time, 2, 3, 5, 6, 10 hours. So this is a very helpful feature in terms of day-to-day management of diabetes that we all we agree that it's can sometimes be very challenging. Insulin to carb ratio is very similar to basal bolus. So patients count the carbs that tell the pump how many grams of carbs they are eating, and the pump is programmed in a way that can calculate the bolus, the amount of insulin that is required for that amount of carbs. And then we have insulin sensitivity or correction factors, similar to what we call it the sliding scale for patients that are familiar with NPH. And what that means is if the blood sugar is not at the target range, how much insulin this person needs to bring that high blood sugar to the target level. And of course you have the glucose target that we program for the pump, and we can have different targets even during different times of the day and night. We can have higher targets at nighttime because we don't want to overbolus, and we can have more tighter control during the day. This is a kind of rather newer feature that the pumps have added to when they upgrade their models. They have added it. It's called insulin on board or active insulin time. Basically, based on the activity curves of insulin, the pump can calculate if 2 boluses are going to be given close in time, how much of the first bolus is still active in the body and can deduct it from the second bolus. So basically, this is to prevent overstacking of insulin. So a common question that we get a lot in the clinic is, are insulin pumps safe? I want for my 2-year-old, for my 4-year-old, what is the age range that you think that insulin pump is recommended? So actually, because of all these features, the younger the patient, the better candidate for insulin pump, the more benefit that they can get from insulin pump. And we will have evidence for that. Any questions so far? Okay. So we have another form of insulin delivery system that is called insulin patch. It's very, very similar to insulin pump. So all the pumps that we mentioned, these 3 types are connected to a very tiny tube, which ends to a cannula, and that cannula needs to be inserted inside the skin, because the type of insulin that we have today needs to go subcutaneously, needs to go inside the skin. And we call it infusion set, and that infusion set needs to be changed every 2 to 3 days. This type of insulin delivery system, which is known as insulin patch, Omnipod is the one that a lot of patients use today. Is like a kind of has an automated cannula that when you activate the pod, inserts that cannula inside the skin. It's almost pain-free. Most patients, almost nobody has to use any kind of lidocaine or any kind of anesthetic, local anesthetics to place it. And it's very convenient because you can use it at multiple sites, different sites of the body. Omnipod has been around for, I think, since 2004 has been approved. And then that small device is like a cell phone, and that's called PDM, Personal Diabetes Manager, which basically is the brain of the pump. And and actually this form can be used also as a meter. So it has a built-in meter that patients don't have to carry another meter. And they enter the amount of carbs. Now, unfortunately, yes, if you drop it, it can break. If they lose it, they have to pay and buy another one. So that's the downside, but it's very convenient. The other type of insulin patch is called Finest. It's from a small company actually in California. It was FDA approved last year for adults. Do you have patients on this, Melissa? No, I don't have either. But that's actually, that doesn't have a basal rate. So it's only for delivery of insulin boluses. So it's mainly useful for patients typically with type 2 diabetes that need meal boluses of insulin. And what is in the market is actually the patches that can deliver 1 unit or 2 units. So basically when the patient kind of clicks, 1 or 2 units of insulin is delivered. And they can count the amount of, like, for example, if they are supposed to deliver 10 units before meal and they are wearing a 2-unit patch, they click it 5 times. Anybody here has used this or is familiar with that? Okay. So again, it seems to be very convenient. It's approved for adults, and it holds up to 200 units of insulin. Needs to be changed every 3 days. So that's one of the newer one. In Europe, there are some other patches, but these are the only ones that are approved in the US.
Except for days or 4 days.
No, very good question. So it's the same insulin that, the rapid acting insulin. So it can be kept in the room temperature for 30 days, basically. Direct heat, of course, is not recommended. Yes? Yeah, basically the device needs to be changed. So what is approved by FDA is because of the risk of infection and inflammation, it cannot. This is a foreign body